Good morning, everybody, and thanks very much for inviting me here. So today I'm just going to give you an overview of some of the areas of research we're looking at in microbiology, but particularly talking about Group B Strep because it's so common. Now Maeve is going to talk mainly on the maternal side, and I'm going to talk about the neonatal side because that overlaps with my role up in Temple Street. So Group B Strep, it's the most common cause of meningitis in neonates, and that's why we worry about it so much. Unfortunately, some of the children can go on to develop very severe neurological disability, and many of them will attend us up in Temple Street for years to come. And I suppose I kind of see the legacy of Group B Strep, and in that way I'm very keen on focusing on trying to improve its management. We also have to remember that it can cause sepsis in the mothers as well. Now, the difficult issue with Group B Strep is 1 in 6 women will carry it. So about 1,300 women a year who come to deliver in the Rotunda will have Group B Strep. Only 1 in 1,000 babies are affected, and only about 5 mothers. So the issue is, how do you spot those, say, 6 or 7 babies and those 5 mothers out of the 1,300 women that come in with Group B Strep? So what we did first of all with Maeve and Zara, we went back and looked at all the maternal clinically significant bacteremias here at the Rotunda, and we published in it in Infectious Diseases and Obs and Gynae. So you can see the most common two consistently for the last 15 years have been E. coli, which is up at about 37%, and Group B Strep, about 25%. And really, apart from 2012, it's been very consistent with about 5 to 6 maternal bacteremia cases a year. Now, they've done huge work on Group B Strep. We all know about intrapartum prophylaxis. So you can see this is data from the US. Originally, the rate was up at about 1.5 per 1,000 live births. American College of Obs and Gynae then introduced the concept of intrapartum prophylaxis. It improved, the consensus guidelines came in. And then around, say, 1999, 2000, the early onset rate there in the solid line has hit what we consider kind of a baseline now, and it really hasn't shifted in the last 15 years. On the other side, you can see the late onset, so that's Group B strep sepsis after 7 days in babies. You can see it's really been static for the last 25 years, and even beyond that. So it's been totally static. And nothing that we're doing is impacting on the late onset strep. So then if you look at the neonatal infections as well, so with Naomi McCallion and Dean Huggard from the neonatal unit, we've looked at our early onset neonatal infections. So you can see we took early onset to be the first 7 days. Group B Strep is way out the most common. The cons may be related to lines, and the second is E. coli. So you can see really if we want to deal with neonatal sepsis, we've got to target Group B Strep. And then on the right-hand side, you can see we've got a chart showing the history of neonatal sepsis at the Rotunda. So you can see in late onset sepsis, it's greatly improved over the last 8 or 9 years. It's been about a 3-fold reduction. And that's due to better line care, improvement in the prevention of neck. But you can see in the green dotted line, the early onset rate for Group B Strep has been static for the last 15 years, very much mirroring the American data. And the purple line at the bottom is the late onset, and again, you can see it's very consistent. So we've looked at different ways, and this was a paper originally started by Mary Cafferty, and then we finished it looking at the issue of Group B Strep Pcr. So can we do Group B Strep Pcr in the neonates to try and help to identify? So what we found is it's a very specific test, so if it's negative, you can rely on that, that's very good. But the sensitivity is only about 85%. So it doesn't capture them all, so you can still have some babies that can slip through the net if you use PCR on all the babies. So now we have a much more restricted program for Group B Strep Pcr. So now I think we've got to the stage you have to revise the situation. So as Rishi was saying, I have my mobile on me all the time because I'm one-on-one on call, so my phone is always on, so I'm nearly wedded to my phone. But up the top, that was the mobile phone that we used in 2000. And nobody would think of using that phone still nowadays, you know? But we're still using the same things for Group B Strep that we used back then, and the rate isn't coming down. So we have to kind of look at more modern technologies if we want to eliminate Group B Strep. So I said the situation is 1 in 6 women, so about 1,300 women who come into the Rotunda have it. Only 1 in 1,000 babies will get the invasive infection. Now we can't treat every baby that is born, because then we're going to run into trouble with lines, antibiotic resistance. So how can we rationalize it? So the couple of things I'm going to mention are things like biomarkers, microbiome, and the vaccine. I suppose I particularly just want to thank the friends at the Rotunda. Maeve will be talking a lot more about the PCR project that we have looking at GBS PCR in adults. So one issue is looking at, can we use biomarkers? So one of them is looking at interleukin-6. So this was a research group from Spain. So what they did is, instead of doing your FBC and your blood culture in the baby, starting the baby on antibiotics, obviously it's time consuming, you have to put in a drip, it's upsetting for the child, for the mother. What they did is they just took an aspirate of the umbilical cord blood, tested it using a point-of-care device like a glucometer in the labour ward, and you can see from the dot plot, it's very clear. Sorry. You can see here in the dot plot, for children who had confirmed bacterial early onset sepsis, the median was about 389, and the median for the group who had no sepsis was 5. So there's a huge margin there. So even if we were to say, okay, we'll test the umbilical cord blood, if it's less than 10, we won't work up a well baby. So if we put the cut there, you can see we drop about half our blood cultures overnight. That would be a huge reduction. So you're using it to screen out. This would be in well babies who've been exposed to GBS in utero. And they've shown that this is a curve that we do to look at, and it performs quite well. Now, to show you the machine, so if we, as I said, if we were to take a cutoff of 10, we'd have about a 50% reduction in our neonatal workups. That'd be 800 fewer babies a year getting treated, and 1,600 fewer lab tests, and 4,000 fewer antibiotic doses. So not only is that the antibiotic, but that's the time for the midwife or the nurse to go and administer the drug to the child. And obviously SHOs will be happy and the mums are happy. Now, to show you the machine, so this is one, there's a couple of different ones on the market. This is the one that probably has the most commercially used. So it's small, it's about the size, as I said, of a glucometer. You have this little cartridge, you put your drop of blood here and you press it into the machine, and it takes about 2 to 3 minutes. And then you get a little reading on the screen. So it's €2,000 for the machine and €2 a test. So you can see, even if we could drop half the number of blood cultures that we do here for early onset sepsis workups, that would be a considerable saving across the hospital. And the other thing is, you don't need a needle, because I know it can be very hard to get umbilical cord blood out using a needle. There's a risk of needle sticks. All you need is to use is a Pasteur pipette, so one of the small little plastic pipettes. They've also done looking at the issue of PPROM. So it's very difficult in PPROM to know which mums will go on to deliver very quickly and which mums will be able to carry the pregnancy for another couple of weeks. So this is a study group in America, and what they did is they looked at the performance of the interleukin-6 using that machine, looking at cervicovaginal fluid as a predictor of infection that was going to develop. So you can see the positive and negative predictive value in their cohort. So the negative predictive value is 97%. So that's very reassuring. So if you have a low value, you can say that you're 97% confident that that woman won't develop chorioamnionitis in the next few days. So it can help to, again, stratify the risk for each of the women. And then this is just to show, and often when people hear about biomarkers, they become very anxious that this is very futuristic technology, you can't implement it in the hospital, etc. So I was very lucky, I'm working with a group in UCD called the Biotope Project. So we're looking for biomarkers for pneumonia in children presenting to regional care centres in Africa. So we're very grateful to the Gates Foundation who funded this project. So what we're doing is, as children present with pneumonia, you have to decide, well, is this a viral pneumonia or is this a bacterial pneumonia? Now, clearly in the African setting, antibiotics are very expensive. There's a lot of problems with drips, getting access to drugs. So if you do give an antibiotic, you want to make sure that that child really needs it, and you don't want to be giving it unnecessarily to children presenting with viral illnesses. So the hope is, again, that we would have a small cartridge machine like that we could put into their emergency hospital. And this is the hospital that we're working with. It's Mzuzu Hospital. It's a small kind of district hospital. But again, they're able to implement this because it's low technology, the consumables are very durable, and then they can run it locally and to help guide the clinicians. Now, I suppose the other area I wanted to mention is looking at the microbiome. Now, often obstetricians go fast asleep when you mention that word because they say, oh, this is ridiculous, because there's an awful lot of hoodoo around and kind of voodoo medicine being practiced. But more and more people are trying to get a scientific grip on the issue. So there's a lot of papers coming out. Now, this is just one. You don't need to know all these bugs. I don't even know half these bugs. You know, with more molecular technologies, they're cropping up all the time. But in this project, what they did is they swabbed normal group, who were women who went to term with no choriamnionitis, had a normal delivery, and the neonates had no signs of sepsis. And then the P-prom group, the group that had preterm premature rupture of the membranes and had choriamnionitis. So what you can see is it's all green, so it's all lactobacillus. And that's what you want in the cervicovaginal area. You want a predominance of lactobacillus, which creates then a quiescent environment so that infection can't take hold. However, if you look at the P-prom group, so this group who developed the infections, you can see there's a huge different range of bacteria present. So the lactobacillus predominance is lost, and then other more invasive infections can take up the space, like streps and anaerobes, and you get this much more mixed pattern. So again, you could take the woman at booking clinic, look at her vaginal microbiome, and predict her risk of developing pre-prom later on in the pregnancy. So again, you can see it's helping us to identify which women are likely to run into trouble during their pregnancy. And then they have a lot of these very colourful charts, but they're called heat maps. Basically, the more red it is, the more of that thing you have. So you can see they've identified 4 different types of vaginal microbiome that exist in women who are pregnant. And basically, group 1 has Lactobacillus crispatus, group 2 is Lactobacillus iners, group 3, and these have very, very low rates of P-prom, exceptionally low rates of infective complications. However, group 4A and 4B have much higher rates of infection, and that's because they don't have the lactobacillus. It's yellow there, they've lost lactobacillus, and thus more infective and invasive organisms can take hold in the environment. So it's one area that, I suppose, moving back a little bit now to Group B Strep. This was a paper looking, again, at trying to predict which women will have babies with invasive Group B Strep. So what they did is they looked at the booking serology on mums whose babies had invasive Group B Strep, and then they looked at mums who were colonized with Group B Strep in their pregnancy, but had a baby that was born well with no no Group B Strep infection. And what they found really is that in the mothers of the neonates, the cases who had invasive Group B Strep, they had much lower levels of antibody against the different types of Group B Strep, as opposed to the mothers of the healthy neonates who had higher levels. So this is showing the principle that if the mum has immunity to the Group B Strep particular serotype that she's carrying in the vagina, she's able to transmit that to the baby, and that is what protects the baby during the first few days of life. And then this, I think, will be the biggest kind of change in my practice in the next 15 to 20 years, will be the introduction of the Group B Strep vaccine. So it's at stage phase 3 trials, which means it's almost ready to come onto the market commercially. And what they've shown is not only do the babies, so these are immune results from the babies, not only do the babies have high levels of antibody against Group B Strep at birth, but interestingly, it will persist to about day 90 of life. So there may actually now be an opportunity to reduce the late onset Group B Strep rate as well as the early onset. I suppose this is a hobby horse. I always take this opportunity to get on this hobby horse about vaccination and pregnancy. So as somebody who works across here and Temple Street, I see both sides of it. And for me, I think all women have the right to access vaccination if they want. If they want the vaccine, they should be able to get their vaccines. Not only does it protect them, but it protects their neonate as well. So obviously you have flu, pertussis, but there's also varicella and rubella that are still very, very important. And I think we have to get our vaccination program right for pregnant women in this country, because once Group B Strep vaccine comes, we need to have a robust program that we can slot it into. And then that way we can hopefully work to eliminate early and late onset Group B Strep. So finally, I suppose I just want to say to people, that I think the time has come that we need to think of new ways to beat Group B Strep. The interpartum prophylaxis kind of process has achieved some reduction, but we're not all the way there. And I think in the next few years, it'll be the vaccine that'll really change things. Better use of biomarkers so we can identify the neonates who need to be worked up. And then finally, I think ultimately to try to understand the whole issue of PPROM, the microbiome, well, that's a bit more down the line. Thank you.